Hi, my name is Dan Price. I'm a head and neck surgeon at Mayo Clinic. We're going to be talking about doing a partial glossectomy. This is a 54-year-old gentleman who had approximately 6 millimeter depth lateral tongue squamous cell carcinoma. We're going to do a partial glossectomy and transverse wedge closure. In this patient, we've also done an elective neck dissection due to the depth of the tumor. One could certainly consider sentinel lymph node biopsy or other modalities, but that typically would cross our threshold for a neck dissection with 6 millimeters depth. Patient is nasally intubated. This gets the ET tube out of the way and makes for easier access to the tumor. Silk stitch is placed through the anterior aspect of the tongue and the mouth exposed with any of the available bite block. The lip should be protected from cautery burns and appropriate FiO2 maintained to avoid airway fire. So you can see the ulcer in the ventral lateral aspect of the tongue, palpating and feeling the depth of the lesion. We'll mark out with cautery approximately a 1 centimeter circumference around the tumor as a guide for the appropriate width of excision of the tumor. Using electrocautery or a laser, you can excise the lesion. There are various philosophies on how to evaluate the margins, but I typically will try to have the margins evaluated off the main specimen. You'll also see that in using the pickups, we try not to grab the specimen itself, as this can create tears in the specimen and artificially create positive margins. It's helpful to make the posterior cut first, as that tissue will retract away from you once that cut is made and become more difficult to access. We're going to cut out a wedge or a canoe-shaped piece of tissue to assure a really adequate deep margin, as ideally we would have negative margins on our first pass. That's prognostic for these patients. And again, ideally we'd have margins taken off of the specimen rather than separate margins. Positive margin in tongue musculature is very difficult to go back and get an adequate margin, and we'll typically take a large margin if that's positive. You can see we're encountering bleeding from the lingual artery. We'll isolate, divide, ligate that with the silk suture ligature. We'll typically encounter this twice in the excision, once anteriorly and once posteriorly. Lingual nerve is in the inferior aspect of the dissection there, and if not involved with tumor, can be preserved. The specimen is oriented on a towel and sutured in place, so it won't move in its passage over to the pathology suite. Once negative margins are assured, we'll close this in a layered fashion, bringing the anterior deep musculature to the posterior deep musculature in a transverse wedge. This recreates the continuity of the intrinsic tongue musculature and gives patients excellent speech and deglutition. We're using horizontal mattress sutures with 3/0 Vicryl for this closure. A variety of different suture materials are adequate. Closing in this fashion also prevents the tongue from being tethered to the alveolus and improves their articulation. We'll typically allow a patient to resume an oral diet with a liquid or pureed diet immediately after surgery, and rarely is a feeding tube required. After our first 2 deep layers have been completed, a superficial layer to seal the surface is performed. Key points: 1 is get adequate margins around the tumor on your initial pass, starting with at least 1 centimeter around the tumor. Transverse excision with a wide, deep margin is critical. Multi-layered closure will provide excellent swallowing and speech, and patients can typically resume an oral diet immediately. That's everything on a partial glossectomy. Thanks very much for watching.